So today we are going to know something about non-union of bones. You know, non-unions, simultaneously we take three things in account. First is malunion, second is delayed union, and third is non-union. Malunion is union having taken place in bone fracture but in altered alignment or altered anatomy. Delayed, but the union, the best part is that union does take place in malunion. The only thing is the structures are not aligned well. They are of course united, but in a different position. Now it becomes our prerogative whether to accept that malunion or not to accept it. If we accept it, then you know the process of remodeling, it goes on for a longer period of time and the fracture does show a functional union. The patient can very well use the limb. So in that status, the malunion is not of problem. But if the surgeon thinks that this malunion is having grotesque deformity in limb, then he may as well think to correct that deformity, and that is deformity correction. So malunion may be acceptable, may be unacceptable. And when it's unacceptable, then we go for deformity correction in order to enhance the function of the limb. Then the second term, as I told you, it's delayed union or non-union. What is delayed union? I told you earlier that we have a more or less agreed time of union. And I told you last time that we have, as per a small, crude, simple formula, we take in upper limb child 3 to 6 weeks, lower limb child 6 to 12 weeks, upper limb adult 6 to 12 weeks, lower limb adult 12 to 24 weeks. So this is the usual time frame to achieve union. But what happens when it doesn't occur? So then we think that probably this union, this fracture is going to either delayed union or non-union. But what is the difference? The difference is when we call it a delayed union, so of course in the mind of the surgeon there is a lurking hope that this fracture is going to unite probably. Isn't it? This fracture, given better immobilization, given some more time, it is likely to unite. So, but the moment we call non-union, one thing is clear, that the surgeon thinks that probably this bony fracture is not going to unite. So this optimism and some amount of pessimism, that is the benchmark of calling a delayed union or a non-union. Now as a doctor we must know that when do we call a delayed union, when to call non-union. You know, one of the very, very important prerequisite of fracture healing, I told you earlier, it must be tender at the fracture line. So long the process of healing is taking place, the fracture must show tenderness at the site of the fracture line. So this is a very good tool in deciding whether this is a delayed union or non-union. Suppose the fracture healing time was say 20 weeks. The patient comes to me at around 20 weeks, 24 weeks. I find there is tenderness at the bone fracture site, but the radiological evidence doesn't suggest that there is bridging callus formation. So what is this? This is probably a case I am confronting with, a case of delayed union, because 20 weeks was the time assigned it to unite. It hasn't united up till now, radiologically and probably physiologically. But what do I find clinically is, clinically I find tenderness at the local site. Radiologically, probably there is some amount of callus from both sides, but it has not become a bridging callus. I told you that the essentiality of fracture union is not only formation of callus, it should be a bridged callus. पुल का निर्माण होना जरूरी है, ब्रिज का निर्माण होना जरूरी है. That is the essentiality of fracture union. So, if these two things are not there, then probably a clinician starts wondering whether I am seeing a case of non-union or not. So, the essential part is delayed union. There is optimism, there is hope that probably if I increase the period of immobilization, probably I increase the quality of immobilization, this fracture should unite. Should unite. There is no rule of thumb here. A case can be very well there when I am thinking probably it should unite, but given time, given better fixation, it may turn out to a non-union. So long I am harboring this optimism, I will call it a delayed union. And the moment the surgeon thinks that probably this is not going to unite, I need to do something. To facilitate union of this fracture. The moment he starts wondering, this is a case of non-union. So, in essence, though there are this much I am trying to emphasize before you, because till today there has not been a definition of non-union. कब उसको delayed union कहेंगे, किस दिन से उसको non-union कहना शुरू करेंगे, there is no definition. People have tried to give definitions. जब हम लोग बच्चे थे, हम लोग जब students थे, तो the dictum was that given double the time of union, suppose a bone unites in 3 months, then give 6 months time. Give 6 months time. If it doesn't unite, non-union. Then FDA, you know, the international organization from America, they said, no, give 9 months time. Triple the time. It can unite, if it doesn't unite, non-union. So you can see the problem that people have, it has been very difficult to give the time frame. A fracture can behave as if it's a non-union much earlier, and a fracture can unite even after double the period of fracture union. So it's all it's difficult to bind them in definition. But the essentiality is, the moment this treating surgeon thinks that until I interfere with this bone fracture, it's not going to unite, it's a non-union. Then coming to clinical features. Clinical features I am telling you before etiology, simply because I just want to make you aware what type of non-union we come across. The non-union, the main clinical finding of non-union is there is absence of continuity of the bone. Hence, you can find abnormal mobility. I have told you earlier that when the bone is intact, it doesn't show abnormal mobility. You can't show abnormal mobility at the mid shaft of the bone. But if there was a fracture and after given some time, twice the period, thrice the period, if there is some amount of abnormal mobility present at the fracture site, this is probably giving us a suspicion that probably some problem is there in the union of the bone. And when this abnormal mobility is free and painless, एकदम free and painless, the patient is just, he is having no pain and it's free, you can do it like this. This is a clear-cut situation when we start thinking whether this is a non-union of the bone. Then absence of tenderness. The moment you start palpating, you look for tenderness, there is no tenderness. And of course, in X-ray, there are different signs of non-union, which I will come to you later. So what is the etiology? What are the etiology? So this etiology, causes leading to non-union are multifaceted. So starting from host related, they are pertaining to नहीं हम लोग बाद में पूछेंगे तो when it's host related, but there will be no pain in non-union. क्यों? क्योंकि simply because all the processes of healing have ceased. Simply because inflammation में तुमने क्या पढ़ा है? Inflammation is body's response of repair to any injury. Injury has already occurred in the bone. The bone has tried, the mother nature has tried every bit to unite the fracture. Because of some reason, some problem somewhere, which I'll come now, there has not been proper union. So what will happen? Mother nature has failed. The process of inflammation has gone to dogs, khatam ho gaya. If there is no process of inflammation, where will you find pain or tenderness? So, non-union, I told you, it's the cessation of effort to unite. एकदम क्लियर कट। जैसे ही हमने कहा कि ये नॉन यूनियन है, इसका मतलब हुआ कि प्रकृति ने एकदम बंद कर दिया कि अब मैं नहीं जुटूंगा, अब मैं बोन को जोड़ने नहीं दूंगा, until you interfere as a treating surgeon. So all the problems will be all problems नहीं, the pain and tenderness part will be completely over. So what are the etiopathogenesis? Etiology, as it depicts old age में body के metabolism जो है वो definitely they go down and there is problem of non-union. Malnutrition, very common in Indian situation. Then smoking, people are very fond of smoking. That is very deleterious thing for a bone to unite. Alcohol abuse, for substance abuse, alcoholic or any, for that matter, any type of substance abuse is leading us to non-union. Systemic disease, diabetes, cancer, metabolic bone disease, osteomalacia, disease like this. Drugs, there are some drugs, and the commonest being non-steroidal anti-inflammatory. We are very fond of prescribing painkillers. Let it be known to you that painkillers, they just play havoc in fracture union. They should not be given for more than a few days. Radiation therapy, they are this high voltage radiation is very detrimental to callus formation, osteoblastic activity. Then infection, mind you, in the presence of osteomyelitis of the bone, just there will be no bone formation in vicinity of the infection. So it's a clear-cut thing that whenever we come across these situations in a fracture, we must deal with very clearly. If there is a history of diabetes, you must control the diabetes throughout. If there is a history of drug abuse or substance abuse, you must clearly tell the patient you can't love both the things. If you want to love your substance, better leave your limb. You can't be having both the things. Then local factors. What are the local factors which may contribute to non-union? Open fracture. I told you earlier that fracture hematoma is the thing in the union of the fracture. And along with open fracture, what happens? Something comes along with it. The chance of infection. So these two things, and the more violent injury, there is more periosteal stripping. And I told you that periosteum, of course, it's just to be regarded as an envelope only, but periosteum is the lifeline of a bone. Simply because periosteum does give blood supply, number one, and periosteum has direct osteogenic potentials. It can directly form bone. Then intra-articular fractures. Why intra-articular fractures? Because again the picture comes clear by the presence or absence of hematoma, fracture hematoma. What happens? In intra-articular fracture, there is too much of synovial fluid in the vicinity. And this fracture hematoma, so to say, is getting washed away by synovial fluid. So, whatever hematoma was being formed, it doesn't accumulate. It just absorbs, it gets absorbed. So, in the absence of hematoma, the union gets jeopardized. Denervation of bone loss, segmental fracture. I told you earlier that there may be fracture at 2 points in a bone, or there may be complete absence of bone. At the site of fracture, one might have extruded a part of the bone. आया वो बीच में 3 इंच का bone gap है, gap fracture, a fracture with bone loss. So all these situations, they can contribute significantly to the formation of non-union. High velocity trauma. People like you very fond of doing bike. कहते हैं ना कि तुम बहुत अच्छे हो तो मुदाले नहीं बन सकते हो, लेकिन मुद्दई तो बन ही सकते हो. You cannot ठोको somebody, but somebody can ठोको you. So, in the era of high velocity road traffic, this is the most significant cause of non-union. Intact fibula. How can intact fibula be a counterproductive thing in the union of tibia? What happens in the fracture of both bones of leg, suppose tibia and fibula? Isn't it possible that the fibula may unite earlier? दो अलग-अलग बोन हैं, दोनों बोन्स में fibula unites earlier. अब fibula union से क्या होगा कि tibia जो है वो कांटेक्ट में नहीं आएगा, वो डिस्ट्रैक्टिंग रहेगा, हमेशा उसको अलग किए रहेगा. Is it clear? So in that situation, tibia may go to non-union, because I told you for proper union there must be reduction, there must be a position of both fractured ends. In that way, there is. Then soft tissue injury. Again the same open injury like open injury. If there is so much of denudation of soft tissue, then they are the cases which go to then local factors pertaining to the fracture. I told you that the essential thing of bone healing or fracture healing is what? It's the presence or absence of blood supply. Suppose a bone has fractured into multiple pieces, and these few important pieces, they are devoid of blood supply. What will happen? That part will be simply rendered avascular. And the moment a part of fractured bone, it's rendered avascular, there will be absence or total cessation of healing activity. Is it clear? And the moment there is cessation of vascularity in the arena, there will be cessation of or delaying of healing process as well. Pathological fractures. Pathological fractures, I told you, they are superimposed fractures on some bone pathology. In later on life, you know, osteomalacia, osteoporosis, they are very, very important landmarks in our industrialized era. What happens? Because of some inactivity, some essential part of malnutrition, there is absence of quality in texture of bone. The bone is not strong enough as it should have been. पुरुषों में because of food, महिलाओं में because of hormonal imbalance. So these two regions, they play havoc in the later part of life. And whenever you find osteomalacia or osteoporosis, this type of bone with low texture is exposed to bone fracture. This type, or even tumors, presence of tumor because of osteolytic lesions or brittle bone, the bone may fracture at very, very low amount of trauma. So this type of pathological fractures, they are prone to go to non-union. Neuropathic fractures. What is neuropathic fractures? A fracture occurring in neuropathic joint or neuropathic bone area. You know, neuropathy is, the neural innervation is very essential for proper nutrition of the bone. And these are one factor when the bone may as well go to non-union. Then the time-tested thing which I told you, when we are enumerating things, you have to enumerate all of them. But the time-tested and most important, I told you earlier, is failure to reduce, failure to maintain reduction, and failure to unite. These three causes are the main causes of non-union. हमने reduce नहीं किया, हमने immobilize बढ़िया से नहीं किया, ऑपरेशन भी किया तो बढ़िया नहीं किया, because operating part is very, very strictly adhered to principles. जो हमने बताया, plate osteosynthesis किया. If I have not honored those 5 principles which I have applied in fracture surgery, probably I am going to fail. And this is one example. This is a clear-cut non-union of bone. Non-union of bone. Why? Because primarily this was not taken care of. The length of the plate must have been more than this. This was not adequate to keep it immobilized in a functional limb. So the surgeon was at fault to let this fracture go into non-union. This is fracture of the humerus. और fracture humerus तुम पढ़ोगे कि fracture humerus is one such fracture where it finds room to unite. Fracture humerus finds room to unite till the surgeon enters the room. मतलब कि ये फ्रैक्चर इतना खूबसूरत फ्रैक्चर है कि मोस्ट ऑफ द टाइम इट गोज बाय नॉन ऑपरेटिव मेथड। लेकिन जैसे ही एक हीरोइक सर्जन कहा नहीं, आई मस्ट ऑपरेट ऑन दिस, एंड he has not followed the principles of fracture, these are the cases which behave very very badly at death. Fracture humerus में 7-7, 8-8 operations हमने देखे हैं अपनी जिंदगी में, जहाँ की the fracture just refused to unite by 7 or 8 surgeries. So it's very difficult. And what was this due to? Simply because a non-operative fracture was given a bad trial of surgery by somebody non-efficient. So this is the status of now coming to types of non-union। इतना सुनने के बाद दो चीजें समझ में आ गई होंगी कि नॉन यूनियन को करने में if we categorize all the etiopathogenetic factors, two types of things come into picture. What are they? The first is mechanical factor. And what is the mechanical factor? Mechanical factor है कि हमने उसको रिड्यूस नहीं किया, हमने उसको रिड्यूस स्टेटस में रखा नहीं, रखा भी तो कॉन्टिन्यूअस मूवमेंट होता रहा। इस तरह के फैक्टर्स को हम कहेंगे मैकेनिकल फैक्टर। एंड द सेकंड वाज जो कि जनरल फैक्टर्स जो हमने बताया, माल न्यूट्रिशन, एब्सेंस ऑफ कैल्शियम, एब्सेंस ऑफ प्रेजेंस ऑफ हैबिट ऑफ स्मोकिंग, ड्रग एब्यूज, जो सारी चीजें जो हमने इन्यूमरेट की, all these things point towards one another factor, and that is biological factor, isn't it? यदि कहीं न्यूट्रिशनल गड़बड़ी रह गई, कहीं वैस्कुलर गड़बड़ी रह गई, तो what is all this? This is all biological factor. So mind you, if you sum up all these etiopathogenetical factors, it comes into under two broad headings. Either there is a mechanical factor responsible for non-union, or there is biological factor responsible for non-union. And depending on these two, we have two types of non-union. पहला non-union है जहां mechanical factors came into play. अब mechanical factors क्या हुए कि Mother Nature tried to unite. Mother Nature ने it just did everything. It formed callus. It formed everything. But because of mechanical reasons, हमने वहाँ movement होते रहने दिया. हमने उसको सही जगह पे रखा नहीं, रिडक्शन को बढ़िया नहीं रखा. हमने रिडक्शन बढ़िया चल रहा था, सब कुछ बढ़िया चल रहा था. ऑन इंसिस्टेंस पेशेंट ने कहा कि सर मेरे भाई की शादी है, हम कोई प्लास्टर नहीं करा सकते हैं। हमारे कहने पे या बिना कहे हुए उसने प्लास्टर काट दिया बिफोर द यूनियन टाइम, एंड देयर इज नो यूनियन टाइम। आई टोल्ड यू देयर इज एब्सोल्युटली नो रूल ऑफ थंब कि आज 60वें दिन हड्डी जुट जाएगा और 61वें दिन एकदम जुटा हुआ रहेगा। नो नो, नॉट एट ऑल। इन द सेम क्लास आई टीच ऑल ऑफ यू, somebody will come with flying colors and somebody will be not, isn't it? So same mahal, same environment, but the fracture behaves differently. So it's never a rule of thumb that this is the period of union. Whatever I have told you is just a basic concept. You must keep it in mind that this is the union period, but it may not follow. And the surgeon or the ignorance of the patient, they might have removed the immobilization, and the fracture which was actually going to unite, it doesn't unite. It went into non-union. So this type of mechanical factors, what we saw that there is some presence of callus in the vicinity. There is some presence of callus, but unfortunately this callus couldn't form a bridge. So this type of fracture was labeled, non-union was labeled as hypertrophic non-union. Hypertrophic non-union का क्या मतलब हुआ कि there is enough of callus, at times more than desirable callus, but it failed to make a bridge. This is the example of hypertrophic callus. और इसी का उल्टा क्या है? एट्रोफिक callus, एट्रोफिक non-union. एट्रोफिक non-union में क्या होगा कि this tapering ends of the bone will be rat-tailed type appearance. वो धीरे धीरे पतले होते जाएंगे. This is what you are seeing as broad fracture ends. In atrophic non-union, the bones will be gradually tapering, and this also bone will be tapering. And this atrophic non-union has been assigned to being because of biological factors. The fracture arena was not being supplied by enough blood vessels. There was drainage of fracture hematoma. So all these biological factors, they came into play, and they have led to atrophic type of fracture non-union. क्यों? क्योंकि atrophic biological failure में क्या हुआ कि callus बना ही नहीं. There is no callus. There will be absence of callus. And in hypertrophic type, you will be having enough of callus, but of course it didn't unite, it didn't form a bridge so as to make it a functional single unit. ये बात क्लियर हो गई? So biological factors में atrophic non-union, mechanical factors में hypertrophic non-union. Then the third one, gap non-union. Since there was a piece of bone, a good chunk of bone, maybe 2 inches, 3 inches, it was thrown out of body and it was not taken care of, the patient fracture has gone into gap non-union. When you find absence of bone in the vicinity. So these are types of non-union. And I'll be sending this slide to your mobile, and you can go through it. So it's very clearly written what type of non-union you are dealing with. So now coming to X-ray picture. Is it some कुछ clear हो रहा है? Now coming to radiology, X-ray picture. So depending on the type of bone, the type of non-union, either the first thing and the most important thing you will find that there is absence of bridging callus. इतना clear है? So as soon as we call it a non-union, at least one thing is clear, that there will be absence of a proper bridging callus. अब यदि callus hypertrophic है, you may find it in variable amount. Then depending on that, we have labeled it at elephant pad sign. Elephant pad sign. Elephant pad कैसा होता है? किसको मालूम है? Elephant pad होगा. This is the bone. This is the bone. और fracture site के पास ये thick हो गया. There may be some callus here and there, but it's not bridged. So this is elephant pad sign. Then something like this, less than this, is horse hoof type. हॉर्स का जो खुर होता है, खुर समझते हो, खुर पैर जो होता है, so horses hoof type, less than this. Then आ जाओ atrophic type है. There will be rat-tailed appearance. The bone will be like this. The fracture site will be like this, atrophic. हमने बताया था फ्रैक्चर यूनियन के समय में कि some amount of bone dies at the fracture end. So not only that natural bony death, there is some atrophy of bone from either side, दोनों तरफ से, and being no callus in the vicinity, it gives appearance of rat-tailed appearance. चूहे की पूंछ की तरह रहेगा, बिल्कुल पतला सा, बिल्कुल वहां पे non-union type. This is atrophic type. So these are things. So there is a fracture line, presence of fracture line, absence of bridging callus. With these things, तो जिस तरह के signs मिलेंगे, and of course in the whole vicinity you will find osteoporosis. And the biggest, a very important thing you will find कि जो फ्रैक्चर हमने शुरू में देखा था, that was sharp edges. जहाँ फ्रैक्चर होता है वहाँ sharp edges फ्रेश में बनते हैं, और वो edges शायद मैंने बताया था कि इतने sharp होते हैं कि during operation they can pierce our skin. Our gloved skin also can be pierced by those sharp edges of the bone. What happens in non-union? The sharp edges are turned into blunt edges. A fracture was like this, which बाद में वो हो जाएगा something like this, एकदम गोल जैसा हो जाएगा. So blunting of front fracture margins, that is very, very common in non-union of the bone. So there will be osteoporosis, there will be smoothing or blunting of the fracture margins, there may be callus, may not be callus in the vicinity depending on what type of non-union it is. Presence of fracture line, all these things may be some intervening pieces of bone in the vicinity, and above all जो सबसे important चीज होती है कि there will be sclerosis of the bone ends. ये bone end जो है एकदम sclerosed हो जाएगा, whitish हो जाएगा दोनों तरफ का. Whatever non-union site is there, we identify it primarily by this sign. There will be sclerosis, bony sclerosis on either side of the fracture. So this in nutshell is radiological findings in when we call it a non-union. So this is the radiological finding. Now coming to treatment. The ideal treatment of any non-union is of 5 steps. What are these 5 steps? The first is open reduction. कहीं भी non-union हो, broadly speaking at your level, you should speak out. Sir, there are 5 steps involved in treatment of bone union. The first is open reduction. You need to open the bone, fracture site. Second, freshening of the margins. What happens? Since these are all sclerosed and fibrosed area where nature has just not allowed it to unite, what I should do? I must freshen this up, and exercise the bone from both sides till it bleeds in a marvelous way. Bone हमने बताया तुमको कि bones are one of the most vascular organs in the body, and whenever you are operating, since they are sclerotic bone ends, if you cut them just like chalk, it will be whitish bone bereft of bleeding. There will be absolutely no bleeding, and you have to reach a bleeder area. You must excise that part of the bone till it starts showing bleeding. So that bleed is the vitality, the sign of vitality of the bone. So excise the bone and all fibrotic tissue in between. At times you can find pseudarthrosis. Pseudarthrosis मतलब pseudo मतलब गलत झूठा और arthrosis मतलब joint. In very long standing non-unions, sometimes what happens, this forms a joint. The area between these two elephant pads, it forms a synovial joint, and sometimes even synovial fluid starts coming out of it. And this has formed a pseudarthrosis, and you know, like other joints, this non-union site can function as a joint. It can function as a joint. So this is pseudarthrosis. It's a type of non-union. So when we are treating them, we must excise whole and everything in between. We must excise the fibrotic material, we must excise the sclerotic bone, and we must excise till it bleeds. And then so first क्या हमने कहा? Open reduction. Second हमने कहा freshening of the edges. Third, effective internal fixation. It must be effective one. It must be very long area on one side and long area on the lower side, or it should be a intramedullary nail. If you want to use blade, it should be a long blade. If you want to use a nail, it should be of entire length of the bone. So, open reduction, internal fixation, freshening of the edges, internal fixation, and the fourth is bone grafting. Bone grafting क्यों? क्योंकि there may be biological factors involved. And what does bone grafting do? Bone grafting helps in three ways. It starts osteogenesis on osteoconductive elements of the bone with osteoinductive principles present there. बताया समझ आ रही बात? The bone grafting, it helps bone formation in three ways. It provides platform. मैंने बताया था कि bone formation osteocyte को हवा में छोड़ देंगे थोड़ी वहाँ bone बनाएगा वो. It must have some scaffold. It must have some आधार, एक आधार होना चाहिए जिस पर कि bone को lay down कर सकता है. So that आधार, that scaffold, that platform is given in form of osteoconductive principles. उस पे bone form होता है. Then osteoinductive principles. हमने बताया था कि bone morphogenetic protein BMP, they are the protein, they are definite type of proteins. जिसमें BMP2 and BMP7, they have been employed in the treatment of non-union. They start osteogenesis, they induce osteogenesis. And the third is osteogenic principles. Osteogenic principles क्या हैं? Osteoblasts and osteocytes, जो उस bone graft में है. So with these, all these elements are found in one type of bone graft in abundance, and that is autogenous cancellous bone graft. ऑटोजेनस मतलब मेरा बोन ग्राफ्ट होना चाहिए, न कि मेरे माँ और मेरे पापा का और मेरे भाई का नहीं होना चाहिए, न किसी फ्रेंड का होना चाहिए, बिकॉज दे आर हैविंग बेस्ट ऑस्टियोजेनिक प्रिंसिपल्स। मेरा बोन ग्राफ्ट मेरे लिए सबसे बढ़िया वो ऑस्टियोजेनिक प्रिंसिपल है। ऑस्टियोकंडक्टिव, इट मस्ट हैव अ प्रॉपर प्लेटफॉर्म, एंड ऑस्टियोइंडक्टिव चूंकि तुरंत निकाल के हमारा ही मेरे अंदर में डाल दिया जा रहा है एक जगह से दूसरी जगह, सो इट मस्ट बी हैविंग दोज ऑस्टियोइंडक्टिव प्रिंसिपल्स इन फॉर्म ऑफ BMP, bone morphogenetic protein. So all these three principles combined, I hope that they will form adequate callus so as to lead to proper bone union. And then the fifth thing is external immobilization. External immobilization मतलब is something like plaster cast application. Because I told you, non-union is a condition where we just understand that nature has ceased to form bone, and I should leave no stone unturned. अब हमको कुछ भी chance नहीं देना है. I must employ everything available to me. मेरे पास जो tools bone form करने के लिए जो tools available हैं, I must utilize them in this treatment of non-union. So all these 5 principles are classically employed in the treatment of non-union. But there is a but here. Science has gone a long way. Now we are in a position to say that whether this is mechanical failure or biological failure. यदि हमें किसी fracture में, if I find in a non-union that there was abundance of callus and no bridging callus, so we all know that probably this was a mechanical failure that has led to non-union. So people started doing, probably these are the cases जहाँ की bone grafting की जरूरत नहीं है. इसमें जरूरत किस चीज की है? जरूरत है a good fixation. तो बढ़िया fixation, because this non-union has occurred because of mechanical failure. The mother nature tried its best to form callus, and it has formed callus. Of course, it doesn't go into its ultimate momentum. वो unite नहीं कर पाया, bridge नहीं हो पाया. So let's give mother nature the best chance to further form bone only when we have given adequate immobilization. And that is कि हमने अपने जो methodology of fixation है उसको हमने बढ़िया कर दिया, reduction को बढ़िया कर दिया, reduction को बिल्कुल दोनों ends को बराबर ले आया. Suppose it was not a good reduction, it may go in non-union. So by operating, I may as well choose not to give bone grafting if I think that this is mechanical failure non-union जैसा हमने बताया. यदि ये atrophic type non-union है, उसमें you must give bone grafting because biological factors के कारण हुआ है. मेरी बात समझ में आ गई? कि knowing fully well that 5 principles must be employed in the treatment of non-union. And what are they? Open reduction, freshening of edges, internal fixation, autologous cancellous bone grafting, external immobilization. ये पांचों चीजें जो हमारे लिए टूल बनी हुई हैं, I must employ them in the treatment of non-union. But since we have known something more because of our study of non-union, we might as well choose that which type of non-union requires what. Mechanical non-union, better mechanics उसको बढ़िया fix कर दो. Mother nature has tried its best to unite the bone, it will again do the best. Atrophic non-union, mother nature ही मेहरबान नहीं थी, तो I must give whatever available to me. तो bone grafting, proper bone grafting हो सकता है, हम उसको कुछ BMP भी डाल दें, और कुछ चीजें हैं जो मैं बात बताऊंगा तुमको. They are employed in the treatment of non-union. छोड़ दें कि बता दें? बता दें? थोड़ी देर में काम करो. I do one thing. I just refer to you 2 or 3 things. Another method of treatment of non-union is by electrical stimulation. Electrical stimulation of non-union site. I leave it on to you. Those who will not find it in books, they can ask me later. And the second thing is induced membrane treatment of गैप नॉन यूनियन. गैप नॉन यूनियन मतलब कि जहां की बोन था ही नहीं या बोन था भी तो इन्फेक्शन की वजह से हमको उसको एक्सरसाइज करना पड़ा. आई टोल्ड यू दैट we have removed so much amount of bone from the non-union site that there is a gap, there is a big gap. और जब big gap हो गया, now it's a gap non-union. So how to treat gap non-union is entirely a different gamut of A. So in these gap non-unions we employ induced membrane technique. Masquelet. It's a French scientist. Masquelet. Masquelet. You know, in French, the T is most of the time silent. So Masquelet technique that's employed in treatment of gap non-unions. And the second is bone transport. I remember having told you that bone transport either by Elizarov method or by AO external fixations. Limb reconstruction method, LRS limb reconstruction system. LRS system or by Elizarov system, we can transport the bone and fill the gap of the gap non-union. So I think we have done everything.